I am a visual economic from Stanford University. It is my pleasure to share our experience at this wonderful conference. Today, I will discuss the preoperative management for patients with Hilar Resection program. Benchmark study was performed in target for Hilar Resection. 8 agent centers and 16 Western centers participated in this study. A total of 708 benchmark cases were investigated in this study. The benchmark values are determined Fabian-Yin 3A or higher, 70%, while weightage 47%, with laboratory rate 90%, and 90-day mortality 13%. Several benchmark studies have been reported in hepatobiliary pancreatic surgery, LVF, RSPN, pancreatic surgery, RSPN. Among them, surgery for pedophile carcinoma was the highest risk procedure in terms of perioperative morbidity and mortality. In particular, 90-day mortality of 13% was much higher than the other. And this study, the benchmark study also demonstrated better overall survival in Asian centers compared to Western centers. In particular, the survival curve showed that more patients died in the early phase Western centers are likely due to perioperative mortality. In this paper, the authors discussed the differences in preoperative management may be a possible reason for the differences in short-term outcome. Implementation rate of preoperative PVE and liver function tests Western center was only half of that in Asian center. A survey on the preoperative management of Hilar carcinoma conducted in Japan and Europe. According to these surveys, there are differences in the indication for portal vein embolization between the two regions. In Japan, most centers perform PV in patients with FMR less than 40%. This practice may contribute to a higher rate of PVE in Japan compared to Europe. In terms of liver functional tests, all centers in Japan conducted ICV tests. In contrast, over 50% of centers in Europe did not evaluate liver function. Our university has been addressing the challenges of pediatric cholangiocarcinoma surgery for over 40 years, continuously refining its preoperative management during this time. The preoperative management protocol has undergone some modification over the years. At first, I talk about preoperative rehabilitation. In a hospital, preoperative biliary drainage is performed for patients with total bilirubin level exceeding 2 milligram per deciliter and or bile duct dilatation in FLR. The primary objective is to resolve cholestasis and liver dysfunction, and the secondary goal is to improve the water flow in the FLR. In the Gleasonian pellicle, bile duct dilatation caused by obstruction reduces portal vein flow, which is under lower pressure compared to arterial flow. On biliary drainage, it compresses the bile duct, and as a result, improves portal vein flow. According to the surveys, type of biliary drainage varies by region. In Japan, biliary drainage is primarily performed via an endoscopic approach, whereas PTBD is a major approach in Europe. Among patients with external biliary drainage, bile replacement is performed in 90% of Japanese centers, but in less than one-third of European centers. However, I understand that performing EMBD and bile replacement can be challenging, as they often cause distress of patients. Previously, we compared the long-term outcome between PTBD and EMBD in patients with peripheral valvular calcium. Overall survival of patients treated with PTBD was significantly worse than those treated with EMBD, with a difference of over 10% in 5-year overall survival. Seeding metastasis occurred significantly more frequently in patients who underwent PTBD, although recurrence rates at other sites were comparable. This data suggests that PTBD may induce seeding metastasis due to bile spillage. Oncologically, endoscopic biliary drainage is preferred to PTBD. Inside stent is placed above the papilla, offering several advantages compared to conventional EBS and EMBD. It can be prevent biliary reflux, which is a cause of retrograde laryngitis, and it is less likely to become obstructed by food delivery. Since it provides internal drainage, there is no need for bile replacement. Recently, commercially available inside stent have become available in Japan. These stents are equipped with retrieval frame, allowing for painful removal. Inside stent is theoretically superior to other stent types. Several retrospective studies investigating the clinical efficacy of inside stents. The figures show the stent patency in patients undergoing preoperative biliary drainage. A central case means to undergo surgery. The time to recurrent biliary obstruction was significantly longer in patients with inside stent than those with EBD or EBS. These studies demonstrated that inside stent was superior to ENVD or EBS in terms of patency in preoperative settings. Now, we use inside stent as a primary method for biliary drainage distribution. We initially relied primarily on PTBD. However, with advancement in endoscopic procedures, PTBD was replaced by ENVD. More recently, we have further transmission to using inside stents as the primary method for biliary drainage. However, ENVD is still preferred for patients with severe jaundice or pharyngitis. The next topic is the estimation of functional result of the future liver remnant. ICKF, understanding green clearance of the future liver remnant, is calculated by ICDK times the ratio of the future liver remnant volume. ICKF evaluates the combination of liver function and remnant liver volume. We previously reported the usefulness of ICKF for predicting post-hepatectomy liver failure and mortality. In patients with ICKF less than 0.05, more than 50% of patients develop PHLF, and the mortality rate was 10.7%. ICKF more than 0.055 has been used as one of the most popular criteria for safe recruitment in extended biliary resection for peripheral angiocarcinoma. Recently, we investigated the predictive value of FLR to body weight ratio and ICKF for PHLF in patients who underwent right glycogenectomy. Univariate and multivariate analysis did not identify ICKF as an independent predictor for PHLF. Instead, FLR body weight ratio with a cutoff value of 0.65%, age more than 65 years, and blood loss more than 25 milliliters per kilogram to be independent predictive factor for PHLF. The absolute volume of the remnant liver appears to be more important than the ratio. Now, we apply both ICKF and FLR body weight ratio as criteria for determining surgical indication in hepatobiliary infection. Next topic is portal vein embolization. The use of portal vein embolization (PVE) has been less common in Western centers compared to Asian centers. In one center in Europe, the policy for applying PVE has been modified since 2016. Following this change, the use of PVE increased from 6.4% before 2016 to 32% thereafter. As a result, the incidence of PHLF and mortality increased. These findings suggest that more frequent use of PVE may contribute to reducing PHLF and mortality. Other, there are several reports highlighting the usefulness of portal vein embolization and hepatic vein embolization. A multi-center retrospective analysis showed that the combination of PVE and HVE resulted in a higher weekly liver growth rate compared to PVE alone. PVE plus HVE induces more rapid hypertrophy than PVE. But in this study, absolute and relative volumes of FLR before and after intervention was almost comparable between two groups. The degree of hypertrophy was 10% in PVE plus HVE group and 9% in PVE group. Although PVE plus HVE induces rapid hypertrophy, the 1% difference may be considered marginal in clinical practice. In my opinion, that's just that. This is my opinion. The efficacy of PVE plus HVE remains unclear. Ethics symbiotics. Symbiotics are a combination of probiotics, which is beneficial bacteria for the gut, and prebiotics, which is nutrients that feed these bacteria. Symbiotics work to, to improve intestinal environment, leading to enhanced immunity and reduced inflammation. We ask patients with hepatobiliary cancer to take symbiotics before and after surgery. After, we ask patients to meet the RCT demonstrated that pre- and post-operative symbiotics reduce inflammatory reaction in patients who underwent major hepatectomy by Hilar Resection. Moreover, patients with pre- and post-operative symbiotics had significantly lower infectious complications than those with post-operative symbiotics. As a result, hospital stay and length of antibiotic therapy were significantly shorter in perioperative symbiotics group. Perioperative symbiotics is safe without side effects and useful treatment. Finally, the application. Sarcopenia is a syndrome characterized by a decline in skeletal muscle mass and strength, primarily observed in elderly. The main cause is natural loss of muscle with aging, but inadequate nutrition, lack of physical activity, and chronic diseases such as cancer and heart failure also contribute. But adequate exercise and nutrition are important to maintain increased muscle mass. We evaluated the impact of sarcopenia on both short and long-term outcomes after hepatobiliary resection for peripheral cardiopathy. Post-operative complications and liver failure occur significantly more often in patients with sarcopenia compared to those without it. Moreover, patients with low muscle mass showed worse long-term outcomes. Muscle mass is associated with post-operative outcomes. In Nagoya University, patients with hepatobiliary malignancy undergo surgery for 1 or 2 months after a preoperative assessment. During the 1 to 2 months waiting time, patients are instructed to exercise and nutritional supplementation at home. Exercise includes walking for than 30 minutes every day and some strength training. Nutritional supplementation includes intake of essential amino acids. This figure shows the changes during the waiting period for surgery. Patients with cancer who underwent no intervention lost body weight and had lower serum albumin and PMI before surgery. But rehabilitation suppressed body weight loss and improved nutritional status. A physical activity is significantly correlated with serum albumin levels and total lymphocyte count. A patient with better physical activity tend to have improved nutritional and immunologic status. The more steps you take, the better your nutritional and immune status becomes. Now, how many steps are minimally needed for better surgical outcomes? When comparing patients who walked more than 5,000 steps a day with those who walked fewer than 5,000 steps, there was a significant difference in the incidence of infectious complications and sepsis. Therefore, walking more than 5,000 steps a day is recommended. Hepatectomy with bile resection remains technically demanding and is associated with high rates of morbidity and mortality. The accumulation of small efforts is crucial for achieving success in challenge surgery for high quality. Thank you for your time and attention.